two things we have been discussing in the past few minutes, rheumatic fever and rheumatic heart disease. Let us clarify on that. So, what is rheumatic fever? Rheumatic fever is when there is activity, there is inflammatory, active inflammation going on inside the body. And in rheumatic fever, the heart may be involved, the joints may be involved, or the basal ganglia may be involved, giving rise to Sydenham's chorea, or you can have, erythema marginatum, or you can have subcutaneous nodules. Is that very clear? What is rheumatic heart disease? Rheumatic heart disease is the burnt out stage of rheumatic fever. That means a child came to us, went to any quack or went to any, general physician with features of, let us say, arthritis, right, and was given NSAIDs. So, what will happen? The arthritis part will resolve. But what about the antibody, the autoantibodies attacking the heart, attacking the basal ganglia? If they attack the basal ganglia, the child will present with Sydenham's chorea. But then, of course, the attack to the heart continues, because it is seen that the rheumatic fever is self-limiting in 12 weeks. Please remember this. 12 weeks. So, even if you leave the child of rheumatic fever without any treatment, many times, this happens in villages, that where the child has some joint pains, they hardly, they would just take the services of a quack or the local tantric and everything, and give some kind of, anti-inflammatory medicines, because of which what happens, the joint manifestations would disappear, but the attack on the heart continues, and then the child comes to the hospital, presents to a tertiary center with features of RHD, because then the heart valves have been destroyed. Now, what happens is that, let us say in a rheumatic fever, what happens is that if we intercept in time, what can be the course? So, this child, if let us say presents to one of the pediatricians with joint pains, and the pediatrician investigates and comes to know that, of course, ASO is elevated, CRP is high, ESR is high, and the child is having migratory polyarthritis. So, the child, he labels the child as acute rheumatic fever and would start two things. What are two things? One, he would start with anti-inflammatory medicines, and of course, he would also start the child on the penicillin prophylaxis, right? But with keeping one thing in mind, that yes, this is a child with acute rheumatic fever, he would also get an echo done. So, if there is heart involvement on echo, we know this is acute rheumatic fever, this is carditis going on, and this heart involvement can be controlled with anti-inflammatory medicines. Now, this heart involvement can be clinical or can be subclinical. If you remember, I told you this is a child. So, I told you this is a child with arthritis, right, and probably does not have a clinical cardiac involvement, but on echo, is seen to be having carditis. So, probably I will escalate my anti-inflammatory medications, right? So, I have two things in my anti-inflammatory medication. I have a bag, of anti-inflammatory medications. I have primarily two drugs in it. Either we have the option of aspirin, or we have the option of steroids. So, it is usually seen that whenever it is seen, many studies have been conducted, whenever there is heart involvement, please always prefer steroids. Please remember this, right? So, heart involvement can be there, so you prefer steroids, and when there is no heart involvement at all, not even the echocardiographic involvement, not even the subclinical carditis, then you can go for, so if there is, no heart involvement, then you can go for aspirin. Now, important thing is how much, what should be the duration? The duration for both of these is going to be 12 weeks. Remember this. This is asked in your exam. So, steroids are usually given. So, 3 weeks we will give full dose steroids, and then coming 9 weeks we will taper. And if it is aspirin, I will give 10 weeks of aspirin, full dose aspirin with 2 weeks of tapering. This is how the child with rheumatic fever has to be treated. And of course, we will start the child on benzathine prophylaxis. How and when it has to be given, that I will tell you in the later slides. But please understand that most of the children coming to the tertiary care hospital, unfortunately, are a case of RHD. So, everything has been burnt out. Already the mitral valve has deformed and has the child presents with features of MR. Now, in this case, what we do is obviously we will investigate the child. We will get a ASO done. We will get a CRP done. We will get a ESR done, right? All these things will come out to be normal. The TLC will be normal. The PR interval will be, can be prolonged, but the TLC over here can be normal. So there'll be no features of activity. What does activity means? Active inflammation. So this child, a case of MR, has to be managed. This child would present to you with obviously congestive cardiac failure. So the congestive cardiac failure has to be managed accordingly. We start with digoxin, we start with furosemide, bed rest is advocated, salt restriction may or may not be advocated depending on the severity of CCF. So this is the usual scenario which we see in our hospitals. The child has already passed the stage of ARF, acute rheumatic fever. But please understand, every child should have first acute rheumatic fever. If it is not treated properly, not proper anti-inflammatory medications for 12 weeks, if they are not given, they will convert into rheumatic heart disease, right? So as I told you, there's an example, the Sydney-Hams chorea patient, the 10-year-old female child came with abnormal movements. So when there is abnormal movements and there is emotional lability and there is hypotonia, and I investigate for all the acute markers, they come out to be normal, and I cannot find any possible case of chorea in this child. There has been no history of drug intake, there has been no neurological insult in the recent past. So then I take it as Sydney-Hams chorea, and please understand, Sydney-Hams chorea, as I told you, is an exception. So in this, that means I don't need any other major criteria or minor criteria for it to be taken as acute rheumatic fever. Straight away, Sydney-Hams chorea means that the child has acute rheumatic fever, and the moment I label the child as acute rheumatic fever, I have to start the child on anti-inflammatory medicine. And in case of Sydney-Hams chorea, I get a echo done. Echo shows absolutely normal heart. Heart involvement has probably not started in this child. So I will very simply give her only aspirin, and that aspirin I will give for 12 weeks. Is this very clear? So this should be very clear, that what is the difference between acute rheumatic fever and rheumatic heart disease. Rheumatic heart disease, the valvular involvement has already started, and now we just have to manage MR or MS. MS is usually not seen in children. It is the MR which is seen in children, and obviously aortic regurgitation can also accompany. But acute rheumatic fever, we have the major and the minor manifestation, and we are supposed to give anti-inflammatory drugs, right?